Good morning, everybody. Just come on in. We're just waiting for everyone to join. As you'll be experienced now with the wonders of Zoom, it works at the speed of light, only it is candlelight. So if you could all come in gradually and take a chair. Once I see that we're filling up and that stops, we'll start with the program. For all those who've joined us, either good morning or good evening, or even what are you still doing up in bed? So let's just see where we're up to with participants coming in. I think we're getting going. Okay. Well, hello everybody, and thank you for coming along to this session on skills for health. This is one of our thematic innovation ecosystems. My name's Andy Bleeden. I work for the European Connected Health Alliance, and we've set up a number of these thematic innovation ecosystems. This one specifically was on the field of skills for health. Now we've designed 3 of these programs to cover what we think are the priority areas for us across Europe and Australia around the field of skilling up both carers and citizens, the workforce, digital health professionals, and then a whole range of different topics. Today's subject is where we need to start around the field of skills and digital health skills. And that's around the idea of skills for citizens and carers. And why wouldn't we start there? Our concept of ecosystems is around matching need and solution, but by leading with a need. So it's patients and citizens and carers first, as opposed to skilling up the digital health professional with many qualifications. There's a reason we do that. As we expect people to grow and use our tools and solutions that we've been very busy supposedly developing with them, we expect them to have the digital skills to be able to use them. My experience is we forget sometimes to tell them and ask them what their needs are in terms of skills training. So today we're going to feature some great input, which starts with needs first and then solutions. There'll be a chance for some discussions later on, and we've got some great speakers lined up today. So many we've squeezed them in, so we're hoping not going to have death by a PowerPoint. And we'll have time for discussion as well towards the end. So come on in, make yourself comfortable, and I'm going to hand over to Karen.
Thanks, Andy. So I'm Karen Butler Henderson, and I am the ecosystem lead for the Melbourne Ecosystem in Melbourne, Australia. We in Australia like to start our meetings with an acknowledgement of country, because our traditional owners of the land here in Australia are extremely important. So I would like to start by acknowledging the traditional owners of the land where each of us are, and pay my respect to elders, both past, present, and emerging. Thank you, and I'm going to hand over to Caroline Studwick.
Thank you. My name is Caroline Studwick. I'm from the region of Southern Denmark, and I coordinate the ecosystem there. And welcome to this event. We had an event back in 2021 where we looked at different target groups when it comes to skills for health. And in this one, we dive deeper into the citizens and carers, as Andy said. But first, we want to start with the need. And at our last session in 2021, one of my colleagues, Randy, talked about how important it is to understand the needs of the citizens and investigate the needs of them in order to develop the right solution. So we're going to try and look at this target group through different sub-target groups. So we have 3 speakers today to talk about different things there. But first of all, I'd like Karen to just tell us how we're going to involve you guys throughout this event.
Thanks, Caroline. So we're going to involve you in a number of different ways. And the first way is to ask if you would share in the chat box where you're from, because we'd really like to be able to get a sense about just how diverse our audience is today. So please add your name and add your country, where you're from. The second way we're going to involve you today is through the use of a Padlet site. We did this at our first session, but for those that haven't seen this before, I'm just going to quickly share my screen and show you what this looks like. So later, after our first 3 speakers, we'll share with you the link to this page, and we're going to be asking this question, so you can start thinking about it now. What knowledge about the needs for digital skills are we missing? Now, for you to be able to add to this, you can either click this little pink plus sign in the bottom right corner, or you can double click anywhere on the screen, type your message and post it to publish it to the page. People can then comment on this, and then you can also click if you like any of these comments on here. The third way is that we're going to allow time to be able to ask questions and share and exchange information. Thanks very much, Caroline.
So now let's get on to the actual content of today and start off with, we have Andy Moore with us from Hello Sunday Morning in Australia. So I'm going to give it straight over to you to talk about vulnerable groups and skills for health.
Cool, thank you. Karen, can you just put my slide, please? Thank you. So yeah, my name's Andy Moore. I'm the CEO of Hello Sunday Morning. And Hello Sunday Morning is an organisation, a tech-led organisation that supports problem drinkers wanting to change their relationship with alcohol. Generally speaking, certainly in Australia, there is a really fragmented drug and alcohol support system. It's not easy to navigate. There are big waiting lists, and very often people wait around, on average, around 18 years before they actually seek out services. And normally when that happens, their life is really falling apart. And so Hello Sunday Morning is really fulfilling a need of early prevention, essentially, to help people before they get to that point, to change their relationship with alcohol. Alcohol, with all other addictions, there's huge stigma associated with seeking help and admitting that you've got a problem, and that's one of the huge barriers to actually taking up services. I'll give you a brief history because it's really important where Hello Sunday Morning came from. It was actually set up about 10 years ago by a young guy who decided to take a year off alcohol and basically blog about it. And during that time, a huge community of people started following his blog and started to be curious about the kind of the movement to stop drinking over an extended period of time. That really morphed in 2016 into an app, which really is a place where people can get support for their drinking issues. It's really built on, it's an anonymous platform, so you don't put any of your details in. It's available 24/7. It's free. It's immediate access. So there are huge benefits for in terms of breaking through the barriers associated with stigma and immediate access. So it kind of fulfills a big need in terms of supporting people before they get to the point of trying to access traditional services. It's really built on the power of peer support. So although we have moderators who are health professionals, we do not really intervene into the service at all. We only intervene into the service if people break our community standards. That is it. It's really built on people with lived experience supporting people with lived experience. They're, along with a basic feed, a day-to-day feed, there are also things like an alcohol tracker and also challenges that you can do as well. But really the power of Daybreak, which is the app, is about the peer support and the fact that there are people with lived experience there to help other people through the journey. We also have another service called Care Navigation, which basically is for anybody who wants to get support outside of our service. We will point them in the right direction, essentially, with a warm referral. And the idea behind that is really to help people navigate, which is quite a challenging and fragmented system in Australia. It's not easy to find your way through the system. So we have somebody with lived experience that can provide that support. We have clinical governance systems to support it as well. So we manage risk on a daily basis, and that gets flagged up, and we manage the risk internally. Really, I think the key thing that we found, although it's an early intervention tool, what we're finding now is that probably about 60% of people that come into Daybreak are at the kind of hazardous levels of drinking and also have very high levels of psychological distress. So although Daybreak was set up as an early intervention tool to start with and has been very, very successful in that, we are now looking to expand our services so that we can cater for people who have more complex needs. In 2019, we did a study with the National Drug Research Institute of Curtin University, which is in Perth of Western Australia. And we found that people who stayed in the app for up to 3 months reduced their drinking by about 50%, and also moderately reduced their psychological distress. Although we weren't trying to, our services aren't there to help people with their psychological distress. That was more of a kind of an add-on, really. We also know that it's a lot cheaper than traditional services because you have immediate access, it's anonymous, the economies of scale are quite huge. So since it began in 2016, we've probably had over 110,000 people register. And on average, we get around 30 to 40 new members a day. And that's just organic growth. That's not with us promoting it or pushing it in any way, shape or form. And that's really because the way that we've positioned ourselves is quite different to a traditional service as well. If you look at the brand and how we talk about ourselves, we almost talk about ourselves in quite an inspirational way. So in a way, what we've done is really try to normalize the conversation around drinking and not drinking and abstinence and moderation, so that it isn't really people on their own suffering in silence. And I think that's where the power of Daybreak comes in, is that people find a clan or a community of people that are like-minded, where they feel that they're not on their own. Just in Australia, the drinking culture is very endemic. Australia is a big drinking culture. So to kind of go against the grain on that and basically tell people that you're not drinking, you're almost seen as, you can almost be ostracized by that. You're almost seen as the person that's the outcast. So Daybreak is a place where people can talk openly and honestly about their issues without worry that they're going to be judged or stigmatized for doing so, because again, it's an anonymous service. I think the challenge for us now is where to from here. We've really positioned Daybreak as an early intervention tool, but as I said earlier, most people now that come in, and we've seen an increase during COVID, definitely, that most people come in now have really quite complex needs. So the challenge for us now is where to from here in terms of the services that we offer. We've just developed a digital health strategy, which basically sets out a stepped model of care within our services, which really start to segment people by their journeys. So when people come into Daybreak, for example, we currently measure their psychological distress, we measure their level of drinking, and we also measure their readiness to change. We also measure their intentions and ask them what their intentions are. So what we're now starting to do is be a bit more nuanced in terms of the journey that people take, and therefore starting to position services accordingly. So someone who just wants to moderate and reduce their drinking is not necessarily somebody, and they have low risky drinking levels, is not somebody that we need to give intensive counselling to or support. You know, the peer support network within Daybreak and, you know, the tools that we provide to support that is really enough for that group of people. However, if you've got somebody who comes in who's had probably, 20 years of heavy drinking, is drinking at very, very hazardous levels, has high levels of psychological distress, then the peer support is not enough. So what we're starting to build is a more clinically orientated services and more intensive clinical orientated services within Daybreak itself and outside of Daybreak, so that people can get more intensive clinical support. For people where we cannot, there is nothing more that we can do in terms of, they would benefit from rehab services or a medical detox, then we're starting to build strategic partnerships with those people so that we can then provide that continuity of care and warm referral into those services. So we're starting to get to the point now where we don't see ourselves as just a digital health service in our own right. We want to add value to the whole sector itself. At the moment, for example, people who are waiting to get into rehab services can wait between 3 to 6 months. Now, someone who needs to get into rehab services, having to wait 3 months is just such a painful and horrendous experience for anybody, because A, they've admitted that they've got a real issue, and B, they want to get support, but they actually can't get it. And so what happens in those 3 to 6 months is crucial. So we're now looking at what support that we can provide people while they're waiting to get into services. And also when they come out of those services, very often it's a revolving door back into detox services, because people's relapse rates are very, very high. So again, what can we do as a service, an online service, to support the existing services and make them better through digital health? And so we're starting to build services and strategic partnerships to help with those problems. The other side of it as well is that we know people suffer from co-occurring issues in high levels. So over 60% of people suffer from high levels of psychological distress. What we want to do is to be able to provide a more holistic service so that we are catering for both their alcohol issues, but also their co-occurring issues. Because very often at the moment in Australia, you either go to get support for your mental health issues, or you get support for your alcohol or addiction issues, but not both at the same time. So from an online support point of view, we want to be able to build the capability of our workforce to be able to support people with co-occurring issues, which really is a workforce capability issues that we've got to provide, because there are very few people in the community, in the workforce, that actually can provide support for both. And we want to position ourselves as an organisation that can provide that. And that, again, that is really about adding value to the service itself. That's kind of it in a nutshell. I think just in the future as well, I think tech is going to play a big role for us in terms of how we can scale up. At the moment, our moderation is very manual, and so is our risk kind of flagging process is very manual as well. So we want to automate that and use machine learning and AI to help us that, and also to be able to serve content through from a CBT point of view as well.
Thank you, Andy. Thank you.
No problem.
So that was hearing from one part of the target group. The next one to speak will be Louise Cambier-Scheel from Denmark, who's from the Danish Association, a membership association for older people. So you're on, Louise.
Thank you for having me, and good morning and afternoon, everybody. So, like you said, I'm Louise Scheel, and I'm a senior consultant and jurist at the Danish Association, a national membership organization founded in 1986. We have 923,000 members out of a total population of 5.8 million. The mission of Danish is to ensure that Denmark is an age-friendly society in which a good and meaningful life is possible for all ages. It entails battling ageism and making sure that support and care is available to those who need it. I spend most of my working hours on digitization and the impact it has on the elderly. Firstly, it's important for me to emphasize that Danish is pro-digitization and technology. Many of the elderly are fond of technology and the possibilities it provides in everyday life. But we do also represent a part of the population to whom it's very difficult or totally unknown, and in some cases inaccessible new territory. Therefore, we focus on a double strategy, fighting for the outsiders, while our 1,700 IT volunteers offer peer-to-peer activities, introducing and helping any and all who's interested in the digital universe and acquiring digital skills, i.e. smartphone classes, installation of apps, teaching how to install and use the new digital identity, MyID. Denmark is often referred to as the most digitized country in the world when it comes to solutions and possibilities provided by the public authorities. You can hardly find any geographical location in lack of digital infrastructure, and the devices have over time become cheaper and more accessible. You should know that Denmark obligates every citizen to digitally correspond with the public authorities unless exempt. An exception would be given if you do not have online access or if you're not able to use your online access. But in general, everybody has to correspond digitally. It's not an easy task for everybody, and even though help is available, a not insignificant amount of the elderly rely on their relatives to help, and in some cases they even hand over their digital signature, including passwords. Just last year, the Danish Agency for Digitization released a report saying that as many as up to 25% of the citizens are digitally challenged, and experts say that the number might be as high as 1/3. In the last 20 years, the government has increasingly hit the gas and digitalized in many areas. Oh, sorry. Hold on. Many of oh, sorry, I just lost track of my notes. Of the public service. In the beginning, the aim was to get everybody on board, but in recent years, we've seen that more realistic approach to the population as a whole, realizing that we cannot get everybody on board, but who are the ones left out? We cannot really generalize when it comes to the population and their digital literacy and skills. Some elderly are interested and already on board, and they have a new smartphone and they book their next trip online. But if it's not age itself, what makes a difference? The data tells us that it's education, job, personal relations, and health, etc. For example, we know that 15 to 19 years old might navigate easily through the digital process of applying for social benefit, but have no clue about the underlying system, including their rights. Whereas some elderly are lost in the digital process, but understand the underlying system. Earlier, we used to focus on numbers of persons who had never been online, but obviously that number is rapidly decreasing, which only tends to complicate matters because it makes it less transparent who's capable of digitally handling their private matters and who's not. Being able to check the weather on an app or stream a TV show is not nearly the same as being able to apply for social benefit or logging in to send a message to your doctor. We're hearing that some people are experiencing a digital fatigue or numbness, so it comes as no surprise that we're getting a lot of emails with frustrations from members who are in fact on board, but on the brink of giving up. They tell us that the pace is too high and or the possibilities too many, and they feel helpless and in some cases left in the dark. And they write this to us in an email. So they're not completely off the grid, but they're getting there. And this might be one explanation. Just within the last year, due to the pandemic, the authorities launched the following: 2 different apps that can show your Corona passport, one for national use and one that can be used nationally and in all of the EU. One website for booking PCR testing and another website for booking vaccines. In addition to this, they launched an app providing a digital version of our social security ID and another digital version of the driver's license. Then come autumn, they launched a new digital signature and identity called MyID. And this spring, they're launching a new digital mailbox where you receive your mail from public authorities. So of course, the pandemic also speeded up the process of changing everyday life. For example, it spiked the numbers of digital visits with the family GP. And we did some polling on that. And when we asked persons who've been online recently if they had digitally communicated with the doctor, the numbers did not vary much in the different age groups, when disregarding the youngest, 15 to 19 years old, and the 85 to 89 years old. So as a group, they're also relatively open to the idea in the future of communicating digitally with your doctor, only disregarding the 80 years old. So we all know that the technology and digital solutions will play an enormous role in the healthcare in the years to come. However, being able to navigate in a digital universe relies on certain sets of digital skills and digital literacy. And interestingly, a recent study in Denmark showed that if you're a woman, or if you're over 40, or if you're a low-skilled worker, you're already set back. So in my case, being a woman who just turned 40, hoping to live to see my great-grandchildren, this is of some concern to me, because apparently I've already peaked. And by the same time, the digitization is not slowing down. And the public authorities and the private sector are pushing forward. Perhaps I must soon turn to my son for assistance. And at the same time, it's extremely important that every one of us not only have the right, but should also be able to handle our private matters for as long as we want, digitally or not. We believe that the goal with digitization should be to add value to the citizen's life, and even more effort should be put into understanding the users when building new solutions. Our user segment is much more diverse than perhaps the 5 or 8 subcategories they're usually divided into. And we're calling for national efforts to continuously educate the public from cradle to grave in the digital universe that has become a great part of not only our private life, but also our citizenship, emphasizing that it is now a lifelong education for all of us, regardless of age. So that was my point of perspective, and I thank you for your attention. I am very open to questions later.
Thank you very much, Louisa. Next up, we have Claire Champet. I think I'm not very good at the pronunciation, but I hope it's okay. From Eurocarers, and now we're moving from the citizen perspective into the carers and who can support these citizens. And this is a European organization. So we've had Australia, Denmark, now Europe in general. So go ahead, Claire.
Yeah, good morning. The pronunciation was perfect. Thank you. I'm very glad to have this opportunity to share the point of view of my organization this morning. And I perfectly agree with what has been said already with Louise about digitalization. I think it's resonated very much with what we hear in our network from carers, who are part of the citizens, and we estimate that 10 to 20% of the population is providing care. Okay. So just as a bit of context, we are a European organization. We're gathering at the same time research organization working on care and caring issues, and carers organization gathering people involved in care as relative, friends, family member of people with vulnerabilities. We as a network, and now more or less the European Union institutions, define informal carers around 3 criteria. Any person, so it doesn't have to be the family, who provide cares in a regular way on long term, unpaid, even if you can have some allowances, but it's not an employment contract, to someone with a chronic illness, disability, or any other kind of long-lasting health or care needs. We advocate for the recognition of the needs of informal carers, of the added value of informal care in our society, which is overlooked most of the time. But we don't promote informal care as such. We're just saying that people should have a choice, whether we want to be a carer, to what extent they want to provide care, for how long, and for which tasks exactly. Importantly, after years of total invisibility in the EU policy-making processes, informal carers are now kind of recognized very officially in reports, and especially this year what this major research synthetic report launched by the European Commission and the Social Protection Committee, so member states also on long-term care, who really consider that informal carers are part of the workforce, and which remind that in the EU, 80% of long-term care is provided by informal carers, 10 to 20% of the population, which represent 50 to 80 of the overall cost of formal care. It's major, it's big. And if you look at, for example, the Netherlands, it amounts to 22 billion euros. I would like now to take you through the difficult relationship between training, education, skills, and informal care through two different angles. First, and this is important for the contextualization of when we discuss digital skills and digital training, there's informal carers face difficulties all through their lives to access education. Sorry, I've been too quick. Yeah, as many young carers experience, it's difficult to achieve education, access graduation, but also when you're in working age, access lifelong training, training on the workplace as part of your career, training as part of the retraining plan, etc. It's all the most difficult if you are providing care to someone which limit your availability, your mobility, etc. etc. As a result, we clearly see that people with caring responsibility are not in a good situation in terms of socioeconomic status. They are systematically behind people who are not providing care, especially when they are not working. This is also because it's more difficult for them to access employment, full-time employment, and retain employment. And this is in this context that they also have unmet needs in terms of care-related skills. So when you provide care regularly to someone, you need to be able to do a certain number of things, especially all what is related to the disease in itself. So the symptom, the management, the treatment, etc. Also, you need to have all these transversal skills that make it possible to you to coordinate services, communicate with health professionals, social carers, to organize things, and importantly, to access all this digital feature of services. And you need also to be able, because caring is impacting on your health physically and mentally, to manage your own situation, so your own health and well-being. And because of a lack of training proposals, opportunities, because they lack availability and time, and because also informal carers do not always consider themselves, recognize themselves as carer and needing support and care, there's big gaps in terms of training for carers. Well, we've been reviewing in our network, many members are very involved in providing training to carers. We've been in different projects, try to screen and review different initiatives and see what is working and not working. And what we see is that there's on one side the health system that is sometimes providing kind of disease-specific training for carers, but which doesn't respect very much their needs and preferences and their availability, etc. And you have on the other side civil society organization who tends to inform, support, and marginally train informal carer, but this is still uneven and not very patchy in terms of initiative and not sufficient. We have set a series of criteria that have to be considered when you want to deliver some training that works. The first is personalized, and this echoes also what with Andy Moore was saying about the different profile of the people you're supporting. It needs to be participative and co-design. It needs to be also not a one-off isolated initiative, but embedded in supporting services. you need to develop adequate pedagogical approaches. You need to combine online and face-to-face, etc. So we have, I won't go into detail, but we have a long series of recommendations on this. But all the most important is to base any initiative on the recognition of skills. The reality is, in most of the cases, informal carers do acquire some of these skills through their experience. And it is very important as part of recognition of the value of care in our society also to recognize these skills and to build on this recognition to construct meaningful pathway toward quality in informal care, improve self-confidence and empowerment among carers, facilitate their reintegration on the labor market, potentially in the care economy, which is facing major shortages. And all this should be part of comprehensive strategies for qualitative care, building of the recognition of the value of care, which is what we expect from European Union strategy that is to be adopted later this year, on which we are working a lot. So we have great expectation from this, especially at a time where a major recovery budget has been open to member states, with including a major priority, one of the top 3 priority, digitalization. We want this to be also supportive of long-term care and informal care. So you might want to keep in touch and follow this policy development, which are quite, I would say, important. It's been years we've been claiming that you need a strategy. We are working to it, which should happen this year. So you might follow us on Twitter. Don't hesitate to send me a mail at this address, and I will try to respond as best as I can. Before thanking you very much for your attention, I just want to raise your attention to one thing, which is this wide survey that we are undertaking as part of the project on long-term care at European level on experience on long-term care. So it's open to everyone above 18 till 20th February. We already have 3,000 responses, and we aim for a little bit more. So we have 3 arguments to put on the table.
Excellent.
You have the link.
Thank you. If you put that in the chat function, Claire, that'd be really helpful. That link for the questionnaire.
Yeah.
Thank you.
Thank you very much, Claire. So from what I can hear on these 3 different presentations, it's very important to be aware that the target groups are very diverse. They have different needs, they have different preferences, they have different skills. So it's very important to understand where they are and how we can help them use these digital solutions that we have. And one thing from what I hear from Claire is how can we train them to be able to use them? And another is how can we design the solutions so that they fit with the skills and preferences that they do have. So now we want to involve you guys a bit more. As Karen told you before, we have our first interactive part of the event where we will use Padlet. If you look in the chat box, then there is a link for the Padlet, and the question that we would like you to reflect on and write some notes on, and there is what knowledge about the need for digital skills are we missing? So what don't we know about the needs for digital skills? So if you go into the Padlet and enter your answers there, and then we will show it on the screen here and see what we get across. So I'll give you a few minutes. It's okay to just take your time to think about it, or you can add on to what other people have said if you wish to.
And vote on them as well, if you like, and add in, if there's someone puts things there that you already agree with, you don't have to type it again, just press like or add your comment into. And put some pictures on there as well, if you like. Nice ones.
You can put non-nice ones on if you want. That's up to you. This type of thing is always open. You can do whatever you want within the law.
Please, no, only nice pictures. This stays on my Padlet wall.
Yeah.
We've got some really great themes already coming out.
Yes.
Like you were saying, Caroline, that topic of, you can see in my post, no blanket approach to every single cohort, population, user group, etc. The access is a really critically important area that's been mentioned, and we're going to keep this up, so we can always come. We can come back and have a look at this again. And what we will also do now is post the other Padlet wall, so you can consider that one as well whilst we move on to the next presentations. Yeah,
and that's actually a good cue for moving onwards to the next section, which is about what this could look like, and that's you, Clara, maybe facilitating that.
It is. Thank you very much. So I would like to welcome our first speaker for our next section, What Does Good Look Like? And it is our own Linda Justy, who's the project manager at Health Innovation Centre in Southern Denmark. Linda will be talking about digital diabetes. And Linda, you are on mute. I haven't been able to say that all week, so it gives you a rush.
Thank you for inviting me. My name is Linda Justy. I work for the region of Southern Denmark. I'm going to talk about a digital communication tool which was developed for vulnerable citizens with diabetes 2. And as to why we did this project, well, particularly in especially vulnerable citizens who often have psychosomatic ailments and who live in group homes, there's an accumulation of lifestyle factors. And they see a difficulty in coping with their diabetes too. So there was a need to help control the everyday habits, especially. Danish municipalities often offer patient educations online, but these vulnerable citizens do not participate in these traditional group-based courses because they have special needs. And so you may ask, why develop something for a marginal group? Well, this is a perfect example of the digital divide because some groups of citizens are often disqualified or overlooked. So there's an urgent need, and now we have a more holistic approach, and we see that health area and the social area are closely connected. So how did we go about it? Well, the digital diabetes is part of a program that has been running for 7 years here in region of Southern Denmark. It develops and implements digital services with a focus on health promotion and prevention. If you look at the graphics, it shows that the target groups and the focus area for this tool. And of course, the citizen is the central. There are errors indicating dialogue and collaboration and notify actions, which I'll elaborate on later. There are also 3 cogwheels, and this is because we need to provide skills for social workers and healthcare professionals in order to form a base of usage. So this is important to say. There's no raised warning finger, no threats. This is solely a nudging approach by the use of notifications and especially visuals. It is behavioral support. It's a tool to interact between the citizen and the carer. Citizen and carer collaboration is thereby improved, because they can discuss both the simple and the complex issues by using this tool as a stepping stone. The hard part in implementation was to get the professionals to download the app. That was a primary obstacle. But we persuaded them to use the tool because we said this will help you form relations. And this appealed to the personnel. Because as we know, I've been working with digital skills for a number of years now, and we must dismantle the fear of using digital technology. And for that, we held some workshops where the personnel participated. And these were joint training courses for both the social workers and the healthcare personnel. And it had a bonus effect because they shared and start sharing perspectives. The implementation itself, we turned around 180 degrees because we said that a minimum of 5 residents and their carers must test this at the group homes. And if they say go, then the head manager would have the final word to implement. So what does good look like? Well, good looks like an app, and the Danish name for it is Mit Liv, and in English, My Life. And you may say, oh no, not another one. Well, this is a very simple app. It contains information, it helps dialogue, it has nudging, and it uses visuals, many visuals. And I can add that the data is stored in the app so that nothing is shared by a third party. The development was that we used user design, and the group, our target group of people could see that this was made for me. So the app contains actions, notifications that you choose. One example could be walk the dog, drink water, drink 4 glasses of water, and you must put into the app how many. So if you reach your goal, then you get a little hurrah. And you must also eat, and you choose how many times a day. It's meant to remind people of the pleasant things, which they sometimes forget due to their ailments. And when you open the app, the first question of the day might be, how did you sleep? And you can choose from 3 smileys, a happy one, a medium one, and a sad one. And this will perhaps help you through the day. And you'll also get a little text saying how to coach with perhaps a bad night of sleep. Also, it's it encourages positive thoughts, and it's also thought to help reduce stress and sorrow and distracting thoughts. This app has perhaps shown a potential to overcome the digital divide and bridge the gap between these citizens and their carers. And the app will stay simple, although developments are coming to help other segments, other health segments of various levels, but it will stay true to its original form. There's a focus on, the focus is still on the vulnerable citizens. So thank you for your attention.
Thank you very much, Linda. Our next speaker is Manisha Aman, who is the CEO for the Centre for Inclusive Design, and she'll be speaking about considerations around inclusive design. Thanks very much, Manisha.
Hello, I feel like I'm speaking to the converted, so happy to talk about this in more detail as we go on as well. I'm sitting in a kitchen space. It's my first day in my first week of a new job. And I know the best way to meet people and understand what they're doing is by catching them on a break. So you can imagine I've been drinking a lot of tea and coffee. There've been a lot of runs back and forth from the bathroom. And then in comes Bob. Bob is in his late 40s. He comes from the central coast of New South Wales, so about 3 hours away from where we are in Sydney. And he has a smile that lights up the room. And we get to talking, and I ask Bob if there's anything that we could do in this new organisation I'm working for to change his life. And if so, what would that be? And Bob tells me that the only thing he wants in life is to have a job. And he can't get a job because he can't finish his studies. And here's the thing. Bob has started a course 7 times. 7 different courses, and I asked him what sort of courses he's picked, thinking we can't all be doctors, right? And he's done everything from photography across to IT, and he just cannot finish a course. And you see, there's a reason for this. Bob was deaf, and is deaf actually. And every time he'd join a course, they'd say that there was an interpreter or captioning services or, translation services. And in every single course, at some point, through the next few years, there would be a subject where they'd say, sorry, we don't have the money for the interpreter. And if that was a core subject, that was the end of his degree. Okay. And it really got me thinking, because his failure had nothing to do with what I thought, which was his intellect or his ability, and had everything to do with the system we'd created, thinking it was okay that it only worked for some people and not for others. And then in the same week, I went to a conference, and I'm sitting there, and I'm not the best in conferences. I tend to fidget a lot, and it wasn't the most interesting of conferences. It was unlike this. It was all about telecommunications, and not an area I know a lot about. But I can tell you, I was absolutely riveted. I learnt more than I have at any other conference, and it's because this conference was actually catered and worked for people with disability. There were interpreters, there were captions, there was transcription and video, and every time I felt my mind wandering, I could look at someone or catch something on a screen and catch up. And as I sat there, I found myself thinking, if we just solved this world, if we just solved things for Bob, that would also solve things for me. And that was the start, in fact, of the Centre for Inclusive Design. And it got us thinking that, what would happen if we created our communities and our research, our practices and approach by focusing on the people who are the most vulnerable to the system's failure. And that failure could be because of age, race, sex, gender, ability, or all other forms of human difference, the things that make us human. And, there's a really interesting thing that happens here from an innovation space, as you all know, because humans are incredibly creative, and we often come up with great hacks and workarounds for systems that don't work. And in fact, people on the edge, people that the system doesn't really work for, are often the instigators of the changes that actually we would never have thought of if we were designing for people rather than with them. An example of that is the electric toothbrush. How many people on the call, you can use the raise hands if you like, how many of you actually use an electric toothbrush? Many of you? Yeah, I can see a few. Some do, some don't. Well, the electric toothbrush was actually designed for people who were bedridden and who couldn't use their hands. You see, because the nurses would have to brush their teeth, and if you have to brush someone's teeth for 2 minutes to make sure that they're clean, that's fine for the first person and the 5th person. By the time you get to the 8th or 10th person, your hand starts hurting. And that was the start of the electric toothbrush. It's now the most effective way for all of us to brush our teeth. The flexible straw was started by and was designed by a man and his daughter. His daughter was a wheelchair user, and she couldn't use her hands, and she couldn't drink her milkshake. And he just felt like it was really important for her to be included in life and to have those little pleasures in a milk bar. These are all examples of mismatch, where the mismatch is actually between the person and the product that it's meant to help. And this is really important when we think about who the edge is, because actually diversity is our mainstream. I think one of the comments that was on the Padlet was about, why do all the people on our screens look the same? There's no good reason when we think about how diverse our communities are. And when we think about our friends and our society, how many of us don't know someone who is older or younger or from a different gender, who is a carer, who is, who has some sort of ability or disability that they have to deal with in their lives. And what people want is not for us to solve everything for them. What they want is individualization. And a number of the speakers today have spoken about technology, and a good way for me, I think, in terms of thinking about inclusive design is the use of, I don't know if you can see it with my screen back there, this thing here, a smartphone. So my guess is most of the people on this call have a smartphone. My other guess is I'd be really interested if anyone, and I'll pop it into chat if you've got it, if any two of us think we use our phone exactly the same way. The reason for that is inclusive design, because if it wasn't for people who couldn't, who were using voiceover, we may never have had Siri. If it wasn't for people with carpal tunnel, we wouldn't have had the technology that now works for gesture control. If it wasn't for these companies, and it's not just my smartphone, but all of these companies working with people who are aging, we wouldn't have this focus on health, as well as the ability to make things bigger and smaller. Now, these things certainly work for edge users or people on the edge, but they actually make all of our lives richer. Okay. And we've done some research and we've found that this actually helps, it increases your market reach and your impact by 3 to 4 times. And it's simple. So we've talked about co-design before in sessions, but how do we do most of this? How do we do it? And there's 3 small questions I'd like you to think about just as a start. The first one is, whatever I'm coming up with, whether it's a workshop or a product or a service or some research, how might this work if there was someone here who couldn't see, couldn't think, who couldn't taste, who couldn't use part of their body, who had children running in the background? How would this work? And then invite the edge in. Okay. Now, we know that this doesn't mean you need a whole lot of people. In fact, we start seeing patterns between 5 and 8 people, 15 max, because we're looking for rich, thick insight, not lots and lots of thin data. Okay. And don't be scared. The biggest barrier to real co-design is often people's worry and shame that they're going to get it wrong. But the work we see is that most people would rather you had an open conversation with them about getting it wrong than not actually hearing their story at all. So let me tell you about one of my favorite stories around how someone has made this work. And it's a woman called Sarah Brown. She's the CEO of the Purple House, run and owned by the Pintupi people in the central deserts of Australia. Okay, so this community were forced from their land in the 1960s in Australia during the Blue Streak missile test. So they tested missiles on their land because this land was far away. There's barely any water. It's away from the towns. But for the Aboriginal people who lived there, this was their home and their country. They had to fight hard to get back on that land, even though it had no water and systems. And when they got there, they had another problem. They had to come off that land again because of renal failure. Because Indigenous people in Australia, especially in remote communities, are 30 times more likely to suffer from renal failure than the rest of the population. And Alice Springs, which is the closest town, hours away, has the largest renal unit in the whole of the Southern Hemisphere because of this. But if you can imagine someone who's fought to be on their country, in their home, now being told they have to go out of that again to sit on a machine, you can imagine the despair that some of these communities felt. They asked for the renal units to be brought into community, and they were told by the government it wouldn't happen because their communities were too far away. But Sarah Brown listened to them. First, they brought community to the groups next to the hospital, and now they actually have transport systems that go out to the community. What started in one community is now in 16 different communities, and Central Australia has gone from having the worst survival rate to the best survival rates for renal failure. And the reason I think this story is really important is not just that they listen to the community, but it flips over that modality that we sometimes have. Even when I think about my parents, that, it's better that you stay in hospital or in that nursing home and live rather than being connected, even if you say that that is more important. Who gets to choose what is the most important, and how do we ensure that people actually are able to get what they need? An inclusive designer will tell you that the system should bend for the user, not the other way around. And if your system is forcing change on people, then it might be time to start thinking about how those people and how the system can be changed for what they want, not what we think they need or what we would want in that situation. So how often do we think that people should be grateful for the care they're given? And when I think about my future self, the one that's elderly and can't hear very well, I just hope that I don't have to feel grateful for a service, but that I get the care I deserve on my terms. So think about your own professional focus. When was the last time you invited some outsiders into the inner circle? What product or service innovations are you missing out on by not doing this? And what is one step you can take tomorrow to change that? Because I promise you, it will be worth it. Thank you.
Wonderful. Thank you very much. So thank you to both Linda and Tamisha for your presentations. Very thought-provoking. And I'm actually seeing a lot of conversation being generated on our Padlet sites that really link in to what both your presentations are. I am going to adopt that new mantra, invite the edge in. In fact, Manisha, we've talked before about the donut, how quite often we design things for that middle class, middle-aged white male, which is at the center of the donut. We need to do better about being able to design at the edge, like you talked about. Caroline, I will share my screen and go back to the first Padlet board if you're happy to just talk us through some of the things that are coming out, and then we can move to the second one.
Sure, thank you.
Am I sharing the right one?
Yep, you are. Oh, but now it's gone.
Oh, okay, there we go.
Okay, there we go. Oh, lots of different things and pictures. Well done. Yeah, so I noticed that Manisha also talked about not necessarily what we can see that they need, but also what do they want? What are their preferences? And I can see that one of the users here has also talked about what people want to use, which is very relevant. I see equality of access, which is also something that we've heard people talk about today. I think Louisa mentioned it, and what does it do to people's access to health if they are excluded from using the services that we generally use in our healthcare? Interrelational skills as well, because sometimes, yeah, digital skills or skills for digital services aren't necessarily about digital skills. They can be about communication skills, interrelational skills, and others. How do you actually do that through digital solutions? And what else do we have here? Motivation, very relevant. What is their motivation actually? Do they want to use this or don't they? That can have a big impact, obviously. I just need to move everybody's pictures so I can see everything here. And format. And I like the fact that is, do we just assume about preferences? I think it's a, can I use bad language in this? Because what I've heard about assume is that assume makes an ass out of you and me. So if you look at the word assume, and I know that's bad, but I'm not English, so I can say it. So really don't assume things, ask people, and they will be happy to tell you more. You like that, Andy, huh? Okay, so yeah, let's go on to the next one, Karen. Let's see what they put on the next Padlet.
Right. Some of the very similar themes coming through on this one as well, such as motivation, and some of the things that, just to summarize, who has my data and trust, privacy concerns, they really go well together. Technology has featured in a number of these posts, connectivity, the actual technology, sometimes it's old technology, it's not meeting the needs for whatever the software is, being able to use that technology, even something as simple as the size of a text for someone that's vision impaired is not able to use that technology. And then there's that siloing that we see. So yet another app talks about how all these apps quite often don't integrate with each other. They stand alone. I know myself, I use one app to measure my steps, another app to be able to monitor my food and drink. I then link into another app to keep an eye on my heart rate. So we need to reduce this siloing. Support for training and education, resourcing to be able to support people. And then that prioritization issue. How do we actually know where to invest our time? What's those most critical problems that need to be answered? It shouldn't be based upon the most number of people that it's going to impact on, but how do we decide what that prioritization is? You can continue posting onto this Padlet site, and at the end, Caroline will come back and talk about what we're going to do with all this information as well. But I will hand over to Andy now, who will be introducing our next exciting section of this event.
Thank you for that. And I think what we've seen today, I just have to say, has been outstanding to squeeze that many speakers in and see so much in terms of what are both the needs, but most importantly, I think some great solutions and some pitches as well, which I think give us a clue to where we've got, I think, shareable knowledge that we cannot ignore. Okay, so we want to have a discussion now, which brings up all the speakers on with their cameras. That'd be kind of useful, because I think we've got a chance for questions from people in the audience. If you can put them in the Q&A below, that's down there next to the chat. If you put it in the chat, we can't see it. Put it in the Q&A, we can. Stick some of your questions in there. Whilst we're on, I'd like to go to, if I could, to Louise, if possible. I was interested to hear what you were saying earlier on. I've got a question for you in terms of needs, I think, which may be coming out from other people as well. If there was one takeaway that you think, if I had a magic button that could say get rid of this as a need, or introduce this in the field that you work in, what would it be?
Oh, but that's not fair.
That's why I thought I'd ask you first, because guess what? Around to the rest of you.
Yeah, it's the whole point. There are so many needs. I think one thing, and that kind of talks against the whole strategy of this country for the last 20 years, or actually, that don't be the motor on the train. Step back and learn from us would actually be what I would tell you. I mean, because we're number one, so maybe get the foot off the gas and learn a little bit more. I would be happy to give someone else the number one position, and maybe let's learn from someone else instead of us making. And I don't believe that the digitization itself is a mistake, but I do believe that it's been forced on a lot of people. So maybe if we took a break, took a step backwards, and just learned a little bit more about why we do it and how we do it, I think that would be my priority, because we're still going to do it, and there's no doubt about it. Just, I mean, we don't have enough hands if we talk healthcare workers, so we need the technology, and everybody's asking for easy access to public service. So it's not a matter of how, do we do it or not, it's a matter of how do we do it smart. And I think that we've not done it the best way all the way through it. I think we did it on the terms of the mass and not of the ones who are challenged, and that's not an inclusive society.
Why do you think that is?
That we've done it like this? Cost efficiency. I think actually the mission was get everybody on board and let's save some money during this process, because there's no doubt that if you put power to paper and have a machine fix a solution instead of having a person do it, then it's cost efficient. And I think that was, and also the ambition, of course, to have an agile society. So I'm not saying that this is on, like, I'm not saying it's only money, but I do believe that the pace of it is set by the expectancies that we could save money and just streamline processes, but not really remember the citizens. Does that make sense? Yeah. So, yeah.
Okay, thank you for that. That's helpful. I'm going to take a small break in this one and ask if we've got audience information, if you've got information you'd like to share as well about what you think are some of the reasons, what could be a really good solution. Put it in the chat function or the Q&A down below, and we'll try and get through as many as we can. Until you start doing that, I keep asking the questions, so it's up to you, and they get more awkward as we go along. So, and all those people who think I can't see them in the screen, you're wrong, because I can see all of you. So keep coming in with some questions. I know we've got people on the call from the Philippines. I'd love to know what's happening in the Philippines. So put some good practice examples there, because that's fantastic. Elsewhere, we've got people calling in from Poland. We've got our Pain Federation people from Poland, the patient access pain people from Europe as well on the call. We've also got people from Scotland and Spain. Nessa, if you can hear me, we want some good practice examples from, and say hello, obviously. Hi, Nessa, and colleagues from Scotland. Some good practice from Scotland. You've put some in already. I'm going to go now to Linda. Okay, Linda. In terms of the field of diabetes, okay.
Yeah.
I'm going to ask you the same question. Okay. What if there was one thing? Okay. From what you've encountered, and obviously, you know, the work you've done there in South Denmark has been, I think, really. You seem to go down and take a really close look at things. But what one thing would you think, if we could change this, just this really annoying thing, it would be this? What would it be?
In respect of sorry.
All right, we'll someone to turn off their speakers on one side of you. That's it. Lovely.
I'm sitting right beside Caroline. It's not that it's her fault. Well, I would say in terms of digitization, well, on a daily basis, I work with digital skills and how to have the healthcare personnel take them in. And we keep returning to this thing called digital literacy. Because if you don't start with the literacy, which is the bottom of the stairs, it's hard to climb the steps. If you don't feel confident with using the digital tools out there, I don't see us getting near the goal.
Okay, that's helpful. Andy, you talked about a really exciting program there, which I'm very interested in finding out more about in relation to the work on alcohol. Yeah. But you've used, you know, some very clean design, some clever, inclusive tricks with digital technology. What have been some of the, you know, and obviously you've chosen to use people putting in information and connections. What role does things like anonymity play with programs like you're operating? Because some people are not comfortable about talking about the mental health problems, and I've known that from 30 years of experience, but certainly around alcohol issues, you're talking about population issue.
Yeah, I would say that stigma and judgment is probably one of the biggest barriers to why people don't access services, traditional services. So giving people the anonymity to be able to share and feel that they're not judged is probably one of the biggest benefits that we've captured. And I think what that's allowed us to do is to capture this kind of middle area of drinkers who believe they've got a problem but don't know what to do about it, and don't wait until their lives are falling apart. So we're hitting this kind of missing middle, the silent middle that people are just struggling with, that, you know, they haven't, you know, gambled all their life away, or they haven't, their marriage hasn't fallen apart yet. You know, they're high functioning alcoholics, of which there are many in society. And I think we've hit on a note around people feeling that they can openly discuss some of their feelings and issues without feeling ostracized by society, because society basically says in Australia that you should drink, you know, and it is the best thing to do. You've got, when we came out of COVID, our state premier basically said we're open for business at 10 o'clock in the morning in a pub with other white male men having a beer, you know, and that's the kind of message that we have in our society. It's the blokey society, it's having a beer, and that is a huge barrier. So the anonymous kind of component of it, the fact that it's immediate access, the fact that it's 24/7 support, breaks through a lot of that kind of stigma and judgment. So I think it's been a big thing for us.
That's helpful. That's helpful. And you could replace your premiere with probably anybody's premiere on this call today with, we're coming out of COVID, let's have a picture of them pulling a pint of beer and everything's going to be okay. Well, sadly it's not, unfortunately. Louise, I'm just trying to see where you are because I haven't got my glasses on. I'm looking for a person who had glasses on. There you are. I can see you now. Louise, sorry. In terms of the work you've done in Denmark with older people, okay, where does stigma play a role in here? Because, you know, we all got those prejudices that, you know, we'll have to be very careful how we talk about technology with older people, and we slow our speech down by about 50% just in case they've gone suddenly deaf. What stigma do you think plays a role? What part does stigma play in people's adoption?
Well, let me just give you the example that I'm a political consultant, so I talk to journalists, and usually they call us up and they say, so how are the elderly liking this? So I have to start the speech by saying, well, we represent 900,000 people and we're just as diverse as everybody else. We have the IT volunteers. The IT volunteers themselves are mostly elderly. The oldest one is like 90 or 85, I think. So the stigma adds to the thing that the journalists likes. They have to put it, you know, like front and center. So they say, so isn't this problem just going to die when the elderly dies? I mean, won't everybody be digital because they die soon, the ones who didn't grow up with it? And we have to tell them, well, it's not, it doesn't work like that. Everybody could get a cognitive dysfunction that makes them not able to use an app or a digital media. So there's a lot of education going into telling everyone that it's not a matter of age, but it's actually the job, the education, the social status, everything else almost than age itself. But it's a work in progress.
Okay.
And Andy, can I jump in? We have two Louises with us tonight, so it's been really entertaining every time we talk about Louise. Our other Louise is at the other end of the aging spectrum, so I might actually ask our other Louise, who we have not introduced yet, but we'll do shortly, the same question.
You know what? I have a little heart attack every time that you say Louise as well, because I'm like, oh my gosh, now I have to respond. It's such a
and
problem,
now I've done it to you.
Yeah, you've really done it to me. Thanks, Karen. Yeah, it's such a problem, isn't it? Like biases, and particularly against the elderly. I'm a practicing psychologist, and some of my clients are elderly because I work across the lifespan. And yeah, there's lots of things that actually they experience which are quite confronting, actually, in terms of bias and stigma. So I love every point that Louise has been bringing up, actually.
And what about the other end of the aging spectrum, the children?
Yeah, children have a bit of an issue with access. So yeah, it's most children who have significant mental health issues, for example, never access treatment, and so never get a diagnosis and never get any kind of treatment. And that's the large majority of them. So it's quite shocking. And that's why we have these cascade effects of mental health issues later on, because most mental health issues kind of kick off before the age of 14. So yes, big problems there too.
We did have one input. Thank you for that, Louise. One input from the Q&As from Scotland, from Nessa, who leads some tremendous work up there. And one of the things that she suggested as well, and this is from Scotland in the UK, is that they hear over and over it's important of options, both tailored, blended and hybrid ways to access services. So give people bloody options, for goodness sake. It's not hard. So I think that that's a really good comment from our Scottish ecosystem partners there. I'm conscious of time. Because I've took my glasses off, I think we're probably going to go to some pictures now. Okay, and while we're lining up our picture, I'm just going to very, very quickly ask Claire, have you got anything to add in from the Eurocarer side of things, where we line up our next pictures?
Yeah, in terms of pointing the most important thing, from our point of view, I would say it's important that people get participate in the design of things, as we said. And for that, you need to structure their representation. And we, informal carers, suffer from a lack of structuration of our representation. Whether in some country you do have an organization representing them very actively and who get a seat at the table. But like in Scotland, you have a Parliament of Informal Carers, which is an annual gathering discussing topics with ministries and everything. But this is very, very rare. And we need to build this structured participation, supporting organization, involving and representing informal care.
Thank you for that, Claire. I'm going to hand over to Carolyn now, because we're going to do what we've tried to do in many of our ecosystems and get some pictures on. So people with really good ideas. Carolyn, over to you.
Yeah, thank you. Well, I'm not pitching, but I will introduce the first pitch. So we have two pitches, one from Denmark and one from Australia, from companies who've thought about the users and their needs when they've built their or designed their solutions. So first off, we'll start with Anders Stær from Butler in Denmark. 2 minutes.
Yeah, thank you for inviting me, and thank you for listening here to this presentation. So what I present and represent is Bubble Bear, which is actually a simple bulletin board, but I just want to elaborate a little bit on what has been discussed here. So what we do is we focus on people and not platforms, right? So even though I present here to you today a platform, it's all about people. So back in 2014-15, we saw that loneliness was increasing a lot. You can see to the left here that loneliness, especially also during COVID, has moved, especially the young ones. And in Denmark, we have this new health analysis being done right now. So we'll see probably also all the other ages, this will increase. When we look loneliness through the rest of the world, it is an increasing issue. So what we said, okay, could we do something about this? So together with 2,500 citizens and 3 municipalities, we said, okay, how can we develop something? I'm not a developer, so I'm just having assistance from somebody who can, but we just wanted to help people get out of loneliness, get into a new community. So we built this solution called Bubble Bear, which is actually a simple bulletin board where you can put up bubbles as a bulletin. And then you can share different things. For example, if you look to the right-hand corner, we have Sanne who has anxiety and feel lonely. Also, we have Tina who's wanted to give back to the community as an informal caregiver. And they have on this platform, together with 420,000 others, put in different bubbles that the citizens find each other. So we see that more and more people help each other with different issues, for example, stress, depression, anxiety, maybe somebody has already had it early in their lives and they give back to other people. So they find each other in a way that they can assist each other. Also, it's the how you could say more everyday life things. So it could be a food club that wanted to, how do you start a food club? How do you, when you are a newcomer to an area, how do you find new friends? How do you find the new community? People can use this app as well. So what we can see is that we've had this evaluated as we are a social impact company. So we have this evaluated together with municipalities and somebody called the Economist Without Borders. I think you have something similar in Australia, but here in Denmark, it's a non-for-profit organization that helps look into what is actually the impact on the community. So they have made this SRI, and it says that actually it brings down loneliness by 40%. It improves the self-confidence and the physical activity, because it's not only the platform. What we can see is that 2/3 of all the citizens who are participating in this platform, they meet up in real life, and that is actually our goal, right? Back to what has been also mentioned by Manisha, right? The accessibility needs to be there, but we use this as a tool to get people to meet up in the real world. So what we do here is that we have no ads. It's important to protect the people, protect the data. We are very focused on GDPR. We are monitoring the data and protecting them. And also we have this accessibility term that we work on every day, so that people who are blind or has other accessibility issues, they can use the platform as well. So we have really tried to focus on the citizens' needs and not being like a tech solution that builds all kind of fancy solutions. And that's also why we actually cover most of the age scale. So today we have citizens from 15 to 96. And when we look at young versus elderly, we can see that from 15 to 30 years of age is primarily around 50% of the users, and the rest of the 50% is I would say grown-ups. And when we look at elderly, they represent 12 to 15% of the users. So as Louisa also said, it's not for everyone that they can use these digital platforms, but we see more and more can. And especially also that the healthcare professionals in the municipalities we collaborate with, they assist the citizens on informing that you have this possibility.
Thank you, Anna. We have to save the time for Louise as well, because we've been talking about Louise a lot now. So, but if you have questions for Anna, you can contact one of us, and then we can get you in touch with Anna. So, Karen, would you like to introduce Louise?
Yeah, thank you. So this is the Australian Louise. Louise Metcalf is going to present George. Thanks, Louise.
Thank you so much. I've really enjoyed this session. It's been amazing to meet you all, and I've loved the discussions. So I've not done a 10-minute pitch in ages, so I hope this is okay. I'm going to start with a story. This is Tom. Tom was just a regular kid, but at 4 years old, he started withdrawing from people, and at 5, he was self-harming. But it wasn't until he was aged 8 that he was finally diagnosed with severe anxiety in hospital. Now that should never have happened. So according to UNICEF, right now, around the world, almost 1 billion children have either severe stress or diagnosable anxiety. And that's the pandemic rate of 1 in 2. And even at pre-pandemic rates of 1 in 5, we knew that more than 2/3 never got help. Wait lists are now at 9 months to get into hospital and 6 months to see a psychologist, even here in Australia, where we have some of the highest treated population rates. It's 90 to 100,000 here. And that drops to 30 in a country like the US, where people often assume there's truckloads of them. And that leads to tens of thousands of children in hospital due to self-harm and at risk of suicide every year. So that's why I'm building George. George is a cute little character. He's a virtual robot helping kids 7 to 12 years old with anxiety and to build resilience. He's AI enhanced, accessible first responder therapy for children with anxiety or issues with resilience due to difficult life circumstances such as divorce or bullying. He also has screens for parents to help them track key symptoms of anxiety, to then take that to treaters to be diagnosed a lot faster. We also co-create with our users, which is quite a challenge. I can tell you some good stories there, but also wonderful to do. He applies the 3 main streams of therapy currently used to treat childhood anxiety: positive psychology for neuroshaping resilience, cognitive behavior therapy, and acceptance commitment therapy. And he also has the goal of stopping childhood suicide and self-harm, which is something that technology can do better than humans. And that gives peace of mind to parents and to treaters as well. He has now over 3,600 downloads, despite literally no marketing budget. Oh, it's just going to be crazy there. Literally no marketing budget, unfortunately. And we've also got supporters in children's hospitals, research centres, even the CSIRO, it's the top scientific organisation in Australia, and the guys that invented Wi-Fi. And they're helping us build our advanced AI. We've done some initial studies with him, so we do have some results, and he shows that around 90% of the children using him experience a significant decrease in panic in the first 10 days, and they sustain it month to month. So, and our users also notice that difference, which is remarkable in mental health tech. So help me make a better world for Tom.
Wonderful. Thank you for that. I'm conscious we've done this record thing of just slightly overrunning. I think some fascinating information from both those pitches. Get your information quickly in the chat function before we close the room up. I'd like to thank all our speakers today. I think we've done what we always said we never can do, which is squeeze as many speakers in as possible. And we're only 2 minutes over. For goodness sake, that's wonderful. I think we've seen some fantastic needs. And so I'd like to thank our people who talked about the needs side, whether it's relating to alcohol, older people, or diabetes. Fantastic. And then some great good practice examples as well. And we've seen lots of information shared in the chat function down below from the speakers who've presented today and our pitch panelists. We've got some great information as well coming in from the Philippines and Scotland down below. I'd like to thank the organisers today from our RMIT. Thank you, Karen, for your dedication and hard work, and to Carolyn as well for your perseverance and patience, and also for Katrine as well, and my colleagues back in ECH Alliance too, Adrian, who's busy trying not to blush from embarrassment there too. I always end on these things with a big so what. I think there's a lot of information here to share and get around and socialise. So use social media to broadcast the best bits of this. We've recorded today and we're going to share it via our web channels and social media channels too. I encourage you all to do the same thing too. The so what question is, what are we going to do next? So we've talked about carers and citizens first. That's important. Next up, 10th of May, same time, same place, obviously not here. Hopefully we'll have the same clothes on. But the 10th of May, at the same time, we're going to talk about frontline staff, okay? Because that's the next thing we need to look at, because we need to skill up those frontline staff, whether they're domiciliary care, healthcare professionals, social care professionals. What's the need and what does good look like? Join us. I'll put the link in the chat function down below because I can multitask despite my best endeavours. There's a link to register. We'll have an agenda up there soon, and hopefully we'll see you all there. Let's continue the conversation off of here on social media. Thank you very much for coming. See you in May.